This is the Limb Lengthening and Reconstruction Society podcast, Distractions, exploring the science, innovation, and people transforming limb deformity and reconstruction. LLRS is thankful for its podcast industry partners, Diamond Level Orthopediatrics, Sapphire Level Orthofix, and Garnet Level Smith & Nephew. In this episode, we join Dr. Manny Kahn and his guest, Dr. Jessica Rivera, as they discuss the Journal of Limb Lengthening and Reconstruction.
Hi, my name is Manny Kahn. It's an honor to introduce our guest today on the Limb Lengthening and Reconstruction Society's annual meeting podcast series, Dr. Jessica Rivera. I've had the opportunity to get to know her as a pillar in the scientific community and through her role as chair of the research committee. She stands out for having the boldness to ask big questions and the passion to find the answer. She's accomplished so much so early into her career, doing her residency at the San Antonio Military Medical Center, a PhD at University of Texas, and a limb deformity fellowship with Dr. Herzenberg at the Rubin Institute in Baltimore. She served 11 years of active duty military service, deploying twice. She was the division chief of research and medical director of the San Antonio Military Medical Center Orthopedic Clinical Research Center. She's an associate professor at Louisiana State University in New Orleans and runs a robust deformity practice and research program. Welcome, Dr. Jessica Rivera. Thanks so much for joining me this morning.
Thanks so much for having me. I'm excited to talk about LLRS and our journal.
Yeah, we're here to discuss your role as co-editor-in-chief of the Journal of Limb Lengthening and Reconstruction, the official journal of the Limb Lengthening and Reconstruction Society. Tell us a little bit about the journal, Jessica.
The journal is currently published twice a year and comprises articles from all over the world, including our international limb lengthening and reconstruction colleagues and our peers within the LLRS. The articles that we publish include everything from editorials to case reports to reviews, such as the systematic reviews and original science. And this can involve basic science topics as well as clinical science topics. So we are really aiming to cover all of the information that we can gain on our amazing field of limb lengthening and reconstruction and be the appropriate home for these articles for our peers.
Awesome. Who should be reading it?
We all should be reading it, the membership of LRS, as well as anyone interested in this field surgically and from a research perspective. It is open access, so it is very accessible. If you do wish to take a look at it, you can go to the LLRS website and you can access the journal directly from our website.
And who should consider submitting and what kind of research?
Well, we publish a lot of different varieties of research, so anyone who happens to be involved in the basic and translational science on limb lengthening and reconstruction topics, as well as anyone taking care of patients that may have clinical research questions. All of these folks should consider submitting research to JLLR. As I mentioned, we publish basic science to clinical science to large reviews, and so I think because we cover the entire spectrum of topics that span what we need to learn and know more about in limb lengthening and reconstruction science and clinical practice. If you have a question that falls into any of that category, you would be eligible to publish in our journal.
Awesome. I know this has been a labor of love, Jessica. Do you mind taking a few minutes to tell us about the journey you and your co-editor-in-chief, Dr. Chris Yobst, embarked upon to get the JLLR to be our society's official journal?
Well, I have to first mention the fact that JLLR is not something that we created within LLRS. A very, very well-esteemed colleague, Dr. Milan Chandri, is who started the journal over 10 years ago. And this was really, truly a effort that he found so important to provide a focused and targeted home for limb lengthening and reconstruction research that may not have the easiest time getting published in traditional trauma and pediatric journals. And so I would say that this is very much his labor of love. But because he was doing so much of the work himself and needed additional support, we had an opportunity several years ago to partner with him and provide some support from our society to transition the journal over to the society being the managing partner in the journal. And so I have to say first, thank you to Dr. Chandri, but we've had several LLRS presidents who have been very integral in that transition. In fact, as far as I can recall, Dr. Austin Fragaman was the president under whom we initially really truly began serious conversations to name an official journal for LLRS. And we had other options, but it seemed clear that JLLR was the place for us to call home. Dr. Steve Quinnen and Dr. Reed Nichols were also following presidents that were very integral in helping us with the transition. As you might imagine, none of us know just right off the bat how to own a journal. And so there were many steps that we just had to figure out along the way. And all of these people were really, really helpful. And then Dr. Yobes and I got named as the initial co-editors once JLLR became the official home for the journal. And this has been a tremendous honor.
Amazing. What a journey. What are your goals for the journal in the long run?
We would like to continue to grow the journal. As I mentioned, we only publish right now 2 issues a year. I think it would be very valuable if we had enough content and enough submissions from our society and other interested researchers and clinicians to have more issues published every year. I can't say what that right number is exactly, but certainly more than 2 would be the next immediate goal. We do aim to publish 3 the next calendar year, but obviously if we continue to grow as an LLRS society, the sky's the limit.
Awesome. Let's highlight some scientific content that's come out in the journal during your tenure so far. I'd like to go through a few studies if you don't mind.
Sure.
There's one study I'd like to bring up that's near and dear to my heart as someone who treats a number of tibial bone defects. A popular strategy is the balanced cable bone segment transport using a ring fixator. I find this technique to be reliable, and I've personally learned some hard lessons. When doing this technique, cables work as a pulley system and pass around a fulcrum in the recipient segment. Dr. Frungberg and his team out of Yale studied different fulcrums. Can you tell us a little bit about this study's design and findings?
Absolutely. So this study used a variety of different options to simulate what fulcrums do for us in the cable tension setup using a sawbones model and monitored how the different cables performed under tension environments. So this was a simulated study, and they studied tension wires all the way to different types of threaded and non-threaded screw options, as well as, I believe, half pins as options to create your fulcrums. I do think that this is a really interesting study because, as the authors point out, one of the major clinical problems in doing cable transport is failure of the cable system to be appropriately tensioned, and it does not transport. And so just having the right equipment going into these surgeries with some of these basic principles being considered could be helpful.
Awesome. Yeah, as someone who's had cables break, I have to go back to the OR because my transport segment isn't moving. I think any simulation in this realm is warranted and welcome so that we don't have to learn our hard lessons on our patients. Frumberg and his team found a tension wire has the lowest cable tension at 16 Newton millimeters and a 3/5 cortical screw the highest at 32 Newton millimeters. Like a lot of biomechanical research, what do you think is the real-world meaning of the observed difference in tension?
Well, I think the question that perhaps we don't know is what is the amount of tension that we need? Many simulated in vitro and simulation studies like this can provide us a range of values, but what we really need in the real world, like what is the amount that we need to actually perform the task in a real patient, that may not be something that we know for sure, but we also get information from this study such as the cables around various types of screws sometimes slip or sometimes jump, and the tension, depending on where that cable is sitting on the screw at any given time, has a tendency to create fluctuations. And so just those nuances, I think, even though we may not know exactly what tension is the right answer, this allows us to at least be thoughtful about why the tension system in vivo may behave a certain way.
All right. Any weaknesses to the study design or obvious next steps to suggest?
Well, the authors are clear that this is a sawbones model, and obviously we don't have the soft tissue tension and the actual bony behavior that you're going to see in a patient. And certainly there's no expectation that this study group set out to replicate the in vivo situation. And so I think that they represented that and discussed that quite fairly. So I guess you could call that a limitation, but they were straightforward about that from the get-go. The next steps probably would be to consider what various limb lengthening and reconstruction surgeons are using, and perhaps even compile an opportunity to work together to see what our complications are and where our failures reside. Perhaps it would be also interesting to see if we can instill a way to measure tension in the operating room to decide, like, we've discovered this tension, and do we have success with our transports or not? Because we still need to know in any different patient situation, what's the right tension? Does that tension need to be changed over time? These are definitely moving things that happen, especially with long transports.
Awesome. All right, let's move on to the next study. I'm going to talk about predicting success of growth modulation surgery in late onset tibia vera. Our good friend Dr. Flanagan out of Atlanta was involved in this study on patients with Blount's disease. In my experience, one of the hardest patient populations I treat include my adult Blount's patients and adult congenital deformities, often complicated by prior interventions during development. So I find this really applicable and the real challenge to treating dynamic issues is that they keep changing. So I think this is such an important thing to study, especially if it can reduce the number of adult Blount's patients we need to treat. I'm being very selfish here. Can you tell us a little bit about this study's design and findings?
Well, this is a large retrospective cohort study that involves a tertiary referral center of a diverse population. So I think that this is valuable in that even though there is a retrospective component to this data collection, this does represent a large population, which is likely representative of many urban centers across the United States. So I think that that is valuable, and the findings indicated that the growth modulation successes were associated with patients with lower BMIs, lower deformity magnitudes, and greater amount of growth remaining. So essentially, situations that weren't exactly quite so bad yet, and situations where the child had growth remaining in order to allow correction of the modulated growth. Those were the things identified as predictors of success.
What do you think this study added to the literature that we didn't already know?
The authors do recognize that their findings were consistent with what was already present in the literature. So I believe we have to kind of consider this in the totality of the evidence that we have so far, that again, this being a relatively large cohort with a representative population to many of our centers in the United States, that this does add to the literature to confirm some things that perhaps are already published. And this is helpful because the totality of literature is always important when we're counseling patients. So I would imagine if one of our pediatric orthopedic colleagues are having this discussion with the family, they can consider how much a skeletal growth the child has. They can consider the child's deformity and better have a informed conversation about what the guided growth option might offer.
All right, I want to get really practical here because it's possibly that next week an adult Blount's patient is going to walk into my office and I need to know what to do. Actually, I scratched out in editing. Sorry. I'm going to start that again. All right, I'm going to ask a really practical question that I can hope can impact the course of patients, hopefully steering them away from ever having to see me once they become adults. Based on this study, what do you think we should do for the obese, late adolescent patient with a large deformity and little growth left? We can get the most that we can from remaining growth to eventually stage, or hold out for growth plate closure and attack the problem with the more definitive means?
Well, it's a difficult question because you describe a patient that may fall outside of the parameter of what this study is finding is associated with success. But success can be measured in a lot of different ways, and obviously we are all wanting to restore the mechanical access of the patient. So even if the patient that walks into that office doesn't have the potential growth remaining and has some other risk factors that may limit the potential to restore the mechanical axis, it doesn't mean that guided growth can't help some. I don't want to minimize any surgery, but if it's possible to get any benefit out of a relatively small surgery, again, not to minimize any of it, it seems to me like it would be worthwhile to get as much bang for your buck as you could with the guided growth option. I do happen to treat some adult patients as well, and these can be very difficult patients to treat in frames with gradual correction. And if it's a very large correction, that makes the opportunity for complications and difficult with healing and difficulty with the soft tissues relative to the pins and wires even more compounded, as opposed to a smaller correction, and any degree will count.
I would say some of the biggest advancements in my framing skills have come from trying to build those extremely highly angled frames. So any weaknesses to the study design or obvious next steps to suggest?
Obviously, this, as I mentioned, a retrospective design, and the authors are good about confronting that there are limitations therein. This may be a great opportunity for the LLRS and other communities that do these types of surgeries to work together for a prospective research to really determine whether or not the guided growth potential is helpful, not only in the parameters that we as surgeons measure, but also what are the patient perspectives on undertaking this type of surgery as a growing child as opposed to waiting to an adult age.
All right, let's move on to another study. We're going to look at a study published titled Qualitative and Quantitative Assessment of the Regenerate Bone Formed During Intramedullary Limb Lengthening Using a Goat Tibia Model, a pilot study. So in the hip-hop world, we often refer to the goat as the greatest of all time, making the goat animal model very appropriate for one of the authors, Dr. Yopes, whose contributions to the field and tenure as LRS president certainly puts him on any short list for the greatest of all time, goat, in what we do. Can you tell us a little bit about this study design and findings?
Well, to echo what you had just mentioned, it's very near and dear to my heart to have a surgeon who's also a surgeon scientist, and Dr. Yopes does animal surgery as well as people surgery. I think that's pretty cool. But this study design uses a large animal model with real-life implants, a magnetically controlled lengthening nail that many of us are familiar with, in order to study the histology and micro-CT characteristics of long bones lengthened with the nail. This is a really interesting question because Elizaroff principles would tell us that disrupting the intramedullary blood supply is not a good thing to do. And we basically threw out that principle when we started using internal lengthening devices. And so really trying to understand the basic science behind how this all works, I think, is not only important, but also very novel.
What did Dr. Yopes' group find when it comes to differences in patterns of healing between external fixation lengthening and internal lengthening nails?
Well, what we know from the previous basic science literature on external lengthening methods is that the distraction segment undergoes a intramembranous bone formation as well as some enchondral bone formation depending on different parameters such as the length of the segment and the rate of the distraction. So it's a mixed bone generation model, but there is a vascular supply central to that lengthening segment, and the periosteum obviously contributes as well. There is also a known interfibrous zone at the very center of the distraction segment, which is not quite patterned just yet when we are thinking about the different layers of the new bone that's being formed. And the ossification that we observe, and we see this radiographically, comes from the cut bone ends. So this is kind of what we already know, but in the presence of an internal lengthening nail, that pattern does change some. And in that, there is still an interfibrous zone. There is ossification from the bone ends, but Dr. Yopes' group identified on histology that there is a second fibrous zone next to the nail, and they term this the inner fibrous zone. And this provided another area of somewhat unpatterned, immature tissue that would later need to be ossified. They also observed, and this validated a radiographic observation by Dahl et al., that there is an ossification that occurs from the periphery where perhaps the periosteum is contributing more, that moves centrally, not just proximally and distally from the bone ends.
Wait. So you're telling me that when we use an internal lengthening nail, we perhaps might actually have a second ossification zone, a second way to form bone from the cortical ends down and from the intramedullary endosteal bone out?
I think that this is happening in either scenario. I think we're forming bone up and down and in and out in both situations. However, it seems to be magnified or at least observed more. I should say it's observed more poignantly in the situation of internal lengthening nail. And the authors propose that this could be because the only blood supply is coming from the periosteal blood supply at that point for that segment because the endosteal blood supply has been disrupted. And so perhaps just shifting where that blood flow is even allowed to be present is providing the more enhanced evidence of healing from the medial lateral perspective on, for instance, an AP radiograph and on this histology, as opposed to the entire thing happening all at once with both endosteal and periosteal blood contributions.
This is amazing. It's so exciting to be alive right now, to see this kind of science coming out and learning more about the strategies that we've been employing for decades already. When we do induced membrane bone grafting, many believe there's an advantage when using IM nails, as the IM space is then filled with hardware. Do you think there's a similar advantage with internal lengthening nails that's been highlighted with this research?
Well, I think the difference there is we're making new bone in distraction osteogenesis. And so just to kind of think about it from the other way, the nail is taking up space where real new pattern bone could be. Unlike in an induced membrane technique where you really never get the same biology as real pattern bone like we do in a distraction situation. So I'm not sure if that's good or bad, but the induced membrane technique likely needs all the help it can get by taking up some space and offloading that to just let the surrounding area heal. But what I do think this study tells us is that the anxiety we may feel about disrupting the endosteal blood supply with an internal lengthening nail isn't necessarily the worst thing that could happen. These bones are still lengthening beautifully. Of course, the histology is a little different, but it's still making real pattern bone at the end of the day.
My mind continues to be blown. All right, so what's your opinion about this? In the goat model, as you can imagine, you can't really limit weight bearing. And in the trauma world, we see clinical studies where when patients are made non-weight bearing because they're polytrauma after an intramedullary nail, and you compare that to when a patient just has a simpler injury and can weight bear immediately, there's differences in healing rates with lower healing rates when non-weight bearing, when weight bearing is restricted during recovery time. Do you think the fact that you can't restrict weight bearing as well in an animal model could have actually accidentally produced a favorable implication in the regenerate formation?
Well, I think that bone loves to be stressed, and so weight bearing certainly, no doubt, is good for that bone. I have been told by those who have worked alongside with Elizaroff that he did not allow crutches in his center, and I may be misquoting that because I have never seen this personally, but I think we go back to the idea of revisiting the very principles of how we want to make distraction osteogenesis and distraction histiogenesis as good as possible, and loading the bone is part of it. And so I think that the goats, even though you can contrive some non-weight-bearing situations in an animal, that's very, very difficult, and they are going to do what they are going to do. And hopefully our patients, we consider allowing our patients to do the same, not only for their overall benefit, but for the health of the bone.
Awesome. Any obvious next steps for this study to suggest?
I think, and as a scientist myself, this is such an exciting study, and I think continuing to understand how this pattern bone heals And larger lengthening situations would be really interesting. Obviously, there's some limitations there to what the animal models can do in that regard. But we do have the opportunity to consider next clinical steps in terms of how might we have a creative way to image this new bone in an internal versus an external lengthening situation. How could we provide some ideas about in vivo testing of the bone integrity, such as with microindentation and different other technologies? Perhaps there's a way we can think about translating these findings to answering these questions in our human patients.
And that's why we have the Chris Yopes and Jessica Riveras of the world. All right, let's move on to another study. Treatment of infected non-union of fractures of the proximal third of the tibia using an Alizarov ring fixator, a case series. In this study out of India, they highlighted 25 cases of infected non-union of the proximal third of the tibia that were treated using an Alizarov ring fixator over the past 10 in patients over the past 10 years. Can you tell us a little bit about this study's design and findings?
This study is a prospective cohort, which I found very interesting because it can be difficult to think ahead and plan to enroll patients to observe how things turn out with these extremely challenging and extremely diverse clinical problems. So this is interesting in that it is a prospective cohort, and yet the authors describe approaching the clinical scenario with a very regimented treatment plan, to think about their frames very similarly, to think about their bony resections very similarly, so not to miss the opportunity to adequately debride the bone or build a nice stable frame. And this study found that the frame allowed them to get the docking sites between the bony resections to heal in the majority of the cases. And they had a relatively low complication rate despite these prolonged frame times.
JLR has a rich history of including studies from around the world. With some of the worst problems we all face, treated with elegant and complex solutions. How do you feel as a journal editor? How do you as a journal editor view international submissions, and do you use a different lens for article selection?
I think our international colleagues are critical for our journal because there is such a rich knowledge and practice history in other areas of the world, especially using frame techniques that I feel like sometimes feel a little bit lost in United States centers. We have so much that we can learn from our colleagues all over the world, and so I read these journal articles and always learn something to say, oh, wow, look at how they built their frame, how they approached the situation, and let's not forget some of the basics of how we can use these amazing techniques. And I think our international colleagues remind us of that and always teach us something new.
What do you think about in this study the fact that their average fixator time was 7.12 months with just one refracture out of 25?
I think that's really pretty remarkable. Some of these large reconstructions can take tremendous amount of frame time. So I think you can look at this one of two ways. You can say 7 months, that sounds like they got their goal achieved in a relatively short period of time after a tremendous reconstruction and likely limb saving event. Others might say, oh, wow, that's way, way too long. My patient's not going to tolerate that. And so this can be viewed one of two ways, as either through the lens of impatience versus the lens of success in a really challenging situation.
Any weaknesses to the study design or obvious next steps to suggest?
Well, I think it is challenging to completely understand, even in a prospective cohort, all of the decision-making that said this person gets this particular surgery versus this particular surgery. And we also have to trust that, adequate surgical resections were undertaken, especially in the setting of the infected non-union. But I think this just reminds us that building in a proper frame, doing a proper bony resection, that these really challenging problems in patients that have already had multiple procedures can give us another option.
Awesome. Let's move on to one more study. This one's titled, When is it safe to remove motorized internal lengthening nails after treatment completion? in this study out of the Limb Deformity Center at HSS, Jason Hallworth and Dr. Rosbrook and their whole team aimed to identify the optimal conditions for motorized internal lengthening nail removal for stature lengthening patients. Can you tell us a little bit about this study's design and findings?
Yes, this is a large retrospective cohort examining the time frame of when the internal lengthening nails were removed and whether or not there were any problems after the removal relative to the radiographic description of the regenerate at the time of removal. The benefits in this situation are that this is a large retrospective series with experienced surgeons in a large tertiary center. The findings did indicate that the nails removed at an average, I believe, of 1 year time is about what most of us do, and is also consistent with the manufacturer's recommendations. There are times when we may perhaps feel like the patients want the nail removed sooner. Other times the patients don't want another surgery and they never want their nail removed. And so I think just seeing that this sweet spot perhaps exists as supported by this retrospective evidence is helpful.
What do you think about the fact that the authors included femurs and tibias in the same series?
Well, I think we all believe that those two bones behave a little differently in terms of their bony healing. But I still think that the question is still the same, and especially in light of the fact that we're counseling patients on a second surgery that is planned, and we have to consider that we're up against some industry recommendation. And I feel like that is something that I have to educate my patients about. Like this is the recommended time frame. However, that doesn't remove our own clinical decision making in this. And so having the breadth of femurs and tibias in there, I think, is pragmatic. But we also have the chance to look at them separately in our own clinical practice and say, well, I think this sweet spot still exists.
There's a reported pretty high rate of regenerate fracture in the literature after external fixation methods without internalization of the hardware. In those cases, there's a particular rush to get the frame off, given the patient experience, right? They're living with a frame. Whereas in internal lengthening nails, is there any downside to leaving the nail in for an excessively long amount of time prior to removal?
That's a question perhaps that we don't really know. Good news is our authors here did describe that in patients that were in prolonged times between the nails being placed and removed, whatever reason that may have occurred, they did not have any problems when the nails were in place for longer periods of time.
Have you ever had anyone disappear prior to internal lengthening nail removal?
I fortunately have not, but I do think it reminds us that we have to counsel these patients up front that in any lengthening situation, there may be a good chance of an unplanned procedure, but there's definitely this planned procedure to take out this nail. I happen to switch my folks to trauma nails pretty frequently, and that goes okay, and that kind of allows us to not worry about any potential risk of leaving the internal lengthening nail in.
That brings me right to my next question. What do you think about a CT scan or transitioning to trauma nails if there's any question about healing?
I think that transitioning to a trauma nail is, especially in an adult patient, seems to be something that I consider a good option. It does not add any additional imaging to the situation, and if we're there for the surgery anyway, I certainly don't mind doing that. And I haven't found any patients really mind the thought of that either.
Awesome. I'm going to get a little controversial here. Any indices you would suggest using for researchers or surgeons alike to help with decision-making about regenerative healing?
Well, I would refer back to our paper, and the authors basically give us this guidance that if you see 4 cortices on your orthogonal radiographs of reliable appearing bone, then you can feel pretty good about it. And that is perhaps not exactly a guiding information if we have something that looks a little bit less than that, such as the trauma literature gave us the Rust score with a 3 cortices rule. And so, but I think that's reminds us of the difference of distraction healing versus the biology of the fracture healing. But I'm not sure about indices. There are many that have been described often for research purposes, such as a maturation index and bone healing index. Unfortunately, some of the definitions across different surgeons and even published papers are not exactly matching. And so this would be a really important thing for us to do as a group to standardize some of this language so that we all are speaking the same language.
Sounds like we need a work group. All right, that'll be it for all the hard science. What advice would you have for someone with ambitions of getting into research in limb deformity off the ground so that they can get to the point where they too could submit to the JLLR?
I think as limb lengthening reconstruction surgeons, we tackle some of the most interesting and difficult problems in orthopedics. And so I would first recommend that nobody be discouraged if you have small cohorts of patients with difficult problems and even very diverse heterogeneous problems within the same general diagnosis. We all face that because we are up against sometimes the last resort problems, especially in the adult tumor and foot and ankle community. So don't feel discouraged about that. And also know that you can reach out to other members of the community and perhaps pool patient data and create cohorts that are bigger than your own just by collaborating. So I would say don't be discouraged. Number 2, definitely don't feel bad about collaborating. But number 3, I would say research, and this is a little bit of my own personal experience, research is best done when you're excited about something and have a little bit of a niche in your practice, which I think most of us kind of do in the whole field of orthopedics. So we have a real opportunity to advance our field just by our own clinical observations and questions that come out.
Awesome. Sounds like you're telling us to follow our hearts. So for our members and listeners, how do you submit JLR journal articles?
Well, as I mentioned, you can access our journal through the LLRS website, but you can also access it through any search engine. If you search the Journal of Limb Lengthening and Reconstruction Society, the journal, as many as journals do, will have an area for instructions for authors and all of the information you need to submit for publication a manuscript.
And how much does it cost?
There is no submission fee or publication fee.
And is it open access?
It is open access.
So you're telling me it's free? It's open access? Oh my gosh, there's going to be a big rush for submissions after this podcast. And how about anybody who wants to get involved with the peer review process?
That would be wonderful to have more folks involved in the peer review process. We are always looking for folks that are interested in providing this help. Is if you were to go to the journal website and create an account just as you would for a submission of a new manuscript to us, that would also allow you the opportunity to indicate that you are available for review.
Thank you so much, Jessica, for sitting down with me. It's always so much fun picking your brain. I actually feel so much smarter now just having had this conversation. I hope our listeners enjoyed it too. Thanks. Take care.
Thank you all.
Thank you for listening to Distractions, the official podcast of the Limb Lengthening and Reconstruction Society. Visit LLRS.org to learn more about the Society and limb deformity and reconstruction.